Welcome to AETCM, the emergency medicine channel. Today we will be discussing a acute stroke which presented to our ED. A 59-year-old female was brought to our ER with complaints of right side weakness since 1 hour. Initial 10-second assessment, patient was conscious, oriented and obeying commands. Her airway was patent, there was no pooling of secretions or gurgling sounds. Breathing, her respiratory rate was 16 per minute. Saturation, she was maintaining a saturation of 99% in room air. Air entry was bilaterally equal. Circulation, her pulse rate was 84 per minute with a blood pressure of 160 over 70. Disability, her GCS was E4, V5, M6. Pupils were 2 mm equally reactive, and in her disability she was complaining of right side weakness. Exposure, temperature was 98 degree Fahrenheit, and GRBS was checked at this point of time. It was 114 milligram per deciliter. Since she presented with a weakness within 1 hour, she is in her window period. So suddenly hypoglycemia was ruled out, and we calculated the quick NHS score, which came to be 7. So she is in her window period. So we want to plan on thrombolysis. So we asked for an emergency CT brain, sir.
So the patient had come to the emergency room. So you diagnosed it as an acute right-sided weakness. So possibility you considered is an acute cerebrovascular accident. From the history, available history, it can be either an infarct or it can be a hemorrhage. So how will you differentiate it from your history, an infarct versus hemorrhage?
Yes, sir. Usually if it is hemorrhagic stroke and all, the patient will be a hypertensive patient with a high blood pressure, and with there can be associated headache also, and sudden onset weakness will
headache
be there.
vomiting will be the most priority of the symptoms will be that. And other one will be an
sudden onset weakness. Usually it can either be a wake up stroke or otherwise also they can present, sir.
Okay.
Other features of hemorrhagic stroke?
Then they will be on any medicines like warfarin and all, any valvular pathology. For that they will be taking warfarin. Drug history will be there, sir.
And then
Seizure history.
Seizure and neck stiffness. That can be there, not always.
So
which has got better prognosis, hemorrhagic or ischemic stroke?
Ischemic stroke, sir.
Among ischemia, embolism, hemorrhage, which has got a best prognosis?
Embolism will improve.
Later
The weakness will reduce.
Maximum improvement can be in embolism than other two strokes, but maximum will be on the onset till a maximum weakness.
Ischemic stroke, which is the common area that is affected in ischemic stroke?
Ischemic stroke will be the internal capsule region.
Internal capsule, basal ganglia, maybe thalamus, midbrain, all those areas. That is deep-seated structures. And embolic stroke, it will usually affect the cortical areas. So the representation will not be that more to your homunculus when you look at the homunculus. So only a smaller area will be affected. Maybe they will just have a hand grip weakness, very minimal weakness only. Again, hemorrhagic stroke, which are the common areas?
Putamen area.
Putamen, basal ganglia, these are the common areas. So area involvement is more. Embolism, it will be a shower sort of, maybe multiple areas will be involved, but total deficit will not be that as compared. But they can have sometimes if it is going to a deep-seated structures, but usually the embolic stroke, they will recover faster. Now, from this point, you have asked for a CT. Before patient is being shifted for CT, what are the things that you need to do for this patient?
Before shifting this patient, we have to check her vitals one more time, her blood pressure, respiratory saturation.
Who is unconscious coming to emergency room, you are shifting this patient for CT room. What are the precautions you take while shifting? This is very important.
This patient GCS was full, sir. But if at all there is a drop in GCS, if at all she is worsening very fastly, we should anticipate an airway compromise. So before shifting itself, we have to, if it is very dangerous to shift this patient, we have to we should secure a definitive airway, then shift, or we should consider all the equipments for intubation and everything. And with that, we should transport the patient with the doctor accompanying, with the person who can intubate.
That's all. We are not considering he is as a human being. We are only intubating and keeping the patient. There are a lot of other things you have to see. Eyes. Eyes will be opened continuously if you are intubating and sending the patient. What precaution you take?
Should close the eyes.
Yeah?
Tape the eyes.
You have to close the eyes or you put eye drops. Then blankets.
Blanket.
Hypothermia
Go
prevention.
to a CT room where the AC temperature will be lesser than emergency room. That should be taken care. If suppose he is not catheterized, catheterization should be done. If it is like that.
Yes, sir.
Then, oxygen, how much you need to carry? Suppose you have to calculate the distance from your ED to the CT room, and you have to see if the patient is having an FiO2 of 40%. If you have a portable ventilator, you have to calculate the oxygen consumption and make sure that that oxygen is adequate. That is many times that will be a problem.
How many
Cylinders
you need to keep?
Carry. Maybe inside the lift, suddenly the oxygen will go away. So that all things you need to calculate and make sure that all those things are there. That is a very, very important thing that you need to do. So you have said regarding the precautions that you will take. Now, what else you need to do to this patient? This patient is going for a CT and he is going to come back after the CT. So before going to CT, you need any investigations to be done. Any other investigation that is very important for this patient?
Sir, there is a risk, it is a high probability that it will be an ischemic stroke, and we are planning to thrombolyze this patient. So before shifting, we should secure 2 large bore IV cannula, and we should take samples for INR, coagulant
Important
INR,
investigation which all you need to take. PT INR.
then
Platelets, then
should be checked, sir. APTT should be checked, sir. Then if at all we are planning to do a CT angiogram also for thrombectomy, creatinine value should be sent.
So all these things will be done simultaneously, but we have to make sure that everything is done.
ECG?
ECG should be checked to rule out any AF or LVH features.
Needed troponin also. So these are the priority investigations. So this investigation, you should, once you are taking the sample, this should be taken, and then only you should be sending this patient to the CT room. What should be your door to needle time?
Door to needle time is actually 90 minutes, sir.
Door to needle time is 90 minutes. So as soon as the patient is in, he should be back from CT within how many minutes?
45 minutes.
Then 20 minutes.
20 minutes and interpreted in 45 minutes.
Interpreted in 45 minutes, the patient should be back. For example, this patient is here in front of you at 10 a.m. By 10:20 a.m., they should be back after a CT. So that is a time frame that is very important, because as you know, the time is brain. So the most important thing, that is 20 minutes. Interpretation should not be taking not more than 25 minutes, and you should be initiating your thrombolysis. So here the window period was within 1 hour the patient has come. So as early you are doing it within 3 hours, that has got maximum advantage.
So when patient come within 10 minutes, the physician should see, then within 15 minutes stroke team should be involved, then within 20 minutes the CT should be taken, and within 45 minutes we should diagnose, and at the 60th minute we should thrombolyze the patient.
Thrombolysis. So that is very important. So all this area, there should not be any delay. So initial, within your 5 to 10 minutes is that your crucial time that you have got evaluating for this patient. Okay. Then why you decided for a CT?
Yes, sir. Sir, our priority is to diagnose a ischemic stroke. So we have to rule out a bleed. So bleed can be better picked up in a CT. So we did a CT. And in early CT, sometimes it will be in normal itself. But normal doesn't mean that there is no infarct. So I preferred CT. Or in our hospital, there is an in-house MRI stroke protocol that can be done. That will include some sequence only. But MRI itself is a little bit delayed process, so I preferred CT.
So now the priority is always remember it is CT. So you can think of a CT angiogram. When you will think of a CT angiogram?
If we have enough time, that means if the patient presents early, and if we have enough time, we can do CT with angiogram, so that immediately after thrombolysis we can take the patient for thrombectomy.
Okay. So you are suspecting a large vascular vessel occlusion. So that is one thing. So what will be the signs of a large vessel occlusion?
There will be dense hemiplegia with speech involvement and all.
So what will be the NIHS score at that time?
NHS will be more, sir.
It will be nearing to your 25. So this is only 7 for this patient. So it is on the lower side. So you are not suspecting a large vessel occlusion. So suppose 2 two indications for an early CT angiogram, maybe as you said, very early presentation, and the second group of patient will be they are out of window period, but they are not beyond 6 hours or 24 hours. So they are coming between that 4.5 to your 24-hour period. So these candidates will be an ideal candidate for any intravascular thrombectomy and all. So that is that time you should go ahead with a CT angiogram. Then in MRI, you said regarding MRI, which is the most important sequence that we wanted. I am telling only one sequence I am going to give you. Which one sequence you want?
Flare.
Flare or diffusion weighted?
Diffusion thing is that if the patient is presenting with a wake-up stroke or within that 4.5 hours that time, so we will have to rule out whether it is an acute or just it crossed the acute phase or not. So that time we will do a diffusion MRI stroke protocol. In that we can see flare and diffusion weighted image. So if there is changes in the flare, that means it is delayed, so we cannot thrombolize that patient.
Okay, the first preference will be the changes start will come from diffusion weighted. So if you have only one option, go for diffusion weighted. So diffusion weighted image is the key. So that's why we have defined that MRI stroke protocol in such a way that we are not wasting much time. We are giving priority to diffusion weighted images and we are getting in the stroke. So what is the advantage of MRI over CT? MRI, CT.
MRI, we can see the infarct, one thing. Then in MRI, bleed can also be seen. Then we are having the GRE sequence in which we can see the vessels also. Tough images are also there, sir.
So it will give an overall idea regarding what further therapy anything is needed.
Yes.
So MRI stroke protocol, as you said, it will take more than 20 minutes for us. So even if it is in any good center, it will take 20 minutes. So CT is still the preferred imaging of the choice. But when you have patients out of window period, very early window period, where you can decide upon your endovascular therapy, at that time you can think of maybe either a CT angiogram or an MRI with an MR angiogram, which covers the blood vessels also. Okay.
So this patient CT was done. CT was normal, sir. And aspect score was coming around 10, sir.
Aspect score of 10. Can you define what is aspect?
Aspect score basically checks the areas of brain, sir. Normal CT means it will be 10, sir. So it will be looking the caudate nucleus, the internal capsule, the lendiform, the insular ribbon, and the M1, M2, M3, M4, M5, M6 areas. Everything is normal, it will be 10, sir. If at all any region is involved, depending on the involvement, the score will come down. So 10 means it is actually good, sir. If it is less than 6 and all, the patient might need a thrombectomy.
Need a thrombectomy, or you will decide on thrombolysis. When you will decide, okay, I should hold on thrombolysis for this patient.
If it is very low, sir, because there is a risk of bleed.
Hemorrhagic. If it is less than 5 and all, you should think twice. Less than 3, definitely you should withhold your thrombolysis. So you are dealing in terms of a larger infarct. So what are the early CT findings that you can consider in an infarct?
Dense NCA sign can be there. Then the Salzay-Guerre differentiation will be lost. Then insular ribbon sign can be there, sir.
Okay, then?
When
you anticipate, when will you start having the CT changes? Till from what time? This patient is coming, you are doing it somewhere around 1.5 hours. So probably it will be normal. Or if it is a large vessel involvement only, you will go into see a dense MCA sign. So otherwise it is going to be, as you said, it is going to be a normal this thing only. When you will anticipate a changes, start changing from a normal CT, when it will start changing? Approximate time frame?
3 hours.
Usually start within 3 hours, but can up to 6 hours. It can be normal also. So 3 to 6 hours is the usual time, but after 6 hours, slowly the hypodense area, everything will start coming up in the CT.
Since the CT was normal, we were planning to do for a thrombolysis, sir.
Can you tell indication, contraindication for thrombolysis?
Thrombolysis indications is acute stroke if the patient is presenting within 3 hours, or we can extend up to 3 to 4.5 hours. Age should be more than 18, sir. NH score between 5 and 25 there.
So after 4.5 hours, it is slightly increasing. Stroke is extending.
That time we will be, if imaging of choice is MRI stroke plot. If there is no flare image, then also we can consider, but otherwise it will be risky, sir. So in that case we will go for thrombectomy and all. then we have to rule out all the contraindications, sir. So the INR, if it is more than 1.7, it is a contraindication. Platelet less than 1 lakh is a contraindication. Then age should be more than 18 and less than 80. Then other contraindications are history of a stroke, ischemic stroke itself within 3 months, or history of any hemorrhagic strokes, or patient is taking any warfarin or any low molecular weight heparin within 1 week if the patient has taken that. Any history of...
But the patient is on warfarin, he has got an embolic stroke. So his INR is less than 1.7. Would you thrombolyze?
Yes, sir, because the suboptimal dose.
You have to thrombolyze. Not everybody taking warfarin, we should not say. Everybody who is taking with subtherapeutic levels, you should thrombolyze them because they have come because of that complication.
Then if the patient is on any newer anticoagulant agent, or if there is a history of any major surgery in the recent 2 weeks time, or any upper GI bleed in 21 days, then any history of aortic dissection, or any history of cerebrovascular accident, any malignancy, pregnancy, and all are
Close the space. It's up to the patient is on dabigatran. Patient on dabigatran. So you will not have any assessment tool with you. So what will you do? Patient on dabigatran for AF has come with an ischemic stroke.
Reversal agent should be given, sir. Praxibine should be given.
Praxibine should be given for this patient. Okay.
If at all this patient is on any 10A inhibitors, then acniximab alpha should be given, sir. Then if heparin and all, actually it is a contraindication, but depending on the condition we can give protamine sulfate and all.
Okay.
So by the time we have arranged, we have involved the stroke team also, then we took a fast sample history to rule out all other contraindications. So this patient, there is no allergy, patient is a known case of hypertension, but patient which was diagnosed 4 years back, and patient is not on any medication. Currently her blood pressure is 160 over 110, so which is not a contraindication for thrombolysis.
160 over 110. What is the target for your thrombolysis?
Sorry, 160 or 100, sir. Target for thrombolysis is 185 by 110. That means before thrombolysis, the BP should be less, systolic BP should be less than 185 and diastolic should be less than 110. And after thrombolysis, the BP should be, systolic BP should be less than 180 and diastolic should be less than 105. So during thrombolysis, we have to monitor the blood pressure every 15 minutes for 2 hours. Then after that, we have to monitor every 30 minutes for 3 hours, and after that every hourly for next 16 hours.
What are the common complications during thrombolysis?
During hemorrhagic transformation will be there. So patient can in such cases patient can have sudden vomiting.
Why this BP cutoff is there? The high BP we should not thrombolyze because suspecting low BP we will not thrombolyze. Why
perfusion will be
thrombolysis? What are the problems of thrombolysis other than the things explained in the textbooks? Anaphylaxis is one of the major complications of any drug, including thrombolysis, because when we are thrombolizing for myocardial infarction, many patients you can see patients are going to hypertension, maybe due to the drug action or anaphylaxis. So we should be very careful. Other than the things written in the books like hemorrhage, all these things. What is the percentage of hemorrhage in thrombolysis?
Percentage of hemorrhage, hemorrhagic transformation.
Transformation during thrombolysis.
15%.
Less than
15 to 10%. So that is the
10%, less than 10% is there. Because we have to explain everything to the bystander.
So how will you brief the bystander regarding thrombolysis? Since been asked. So what is the risk versus benefit for this patient?
Sir, since this patient is only 59 years old and she presented in that window period with an NHS score anyway comparatively less, that is it is only 7. So we should explain that we are giving a medicine that that should be given within this time, so that will benefit the patient more. And she is having a right side weakness, so she is a right-handed person, so that also will benefit more. So but the side effect is anaphylaxis and this hemorrhagic transformation, which is comparatively unlikely for her because of the low NIH score and all. So comparing the risk factors, benefits are more, sir.
Benefit are more, and also the profession of the patient. Very important. You have to ask for the profession, what she is doing. So when you look for a drug that is like 50,000, you have to look for the cost benefit analysis. You have to look for what is the cost that you are going to provide, and lifelong how much she is going to gain after getting this drug. If she is getting this drug, this will be her benefit. If she is not getting this drug, this is that quality of life that she is going to have. Maybe it is not a life threatening, there is no much mortality benefit, but when you look at the quality of life, definitely there is going to be a change who have thrombolized and who have not thrombolized. So that part you have to specifically tell the family, and you have to make them convince and get a consent for thrombolysis. So many a center, they will not tell this. They will just say regarding thrombolysis and bleeding, they will not agree for it. So many patients will be lost during the time frame. Very small quantity of acute ischemic stroke is only coming within window period to the emergency room. Yes. When you look at the overall burden of stroke, only very less than 5% of patient is only coming who is fitting for thrombolysis to emergency room. Yes. So the other 95% we are missing actually. So those group, we need to convince them, then only they will be ready for thrombolysis.
In singers, teachers and all, sound and all will be important, so that all will benefit them.
They all benefit, and even their NIHS score is low for a singer or a teacher, maybe a 4 or 3 NIHS, but she has got some aphasia or some involvement. They can definitely, in that group also, you can give for thrombolysis. Ideally 5 to 25, but even 3 or 4 depending upon the profession.
She no other medical or surgical history for this patient. Last meal was taken 4 hours back, sir. Even she developed weakness of the right upper limb and lower limb since 1 hour, and there is weakness, definitive weakness of 2/5 over the right upper limb and weakness associated with slurring of speech and deviation of angle of mouth to the left side. No history of any headache, fever, vomiting, seizures, involuntary maturation, chest pain or palpitations.
COVID negative.
COVID test was also negative, sir. So this patient, already the INR report came as 0.9, and blood pressure is also controlled, stroke time was also involved. Then before thrombolysis, we have to place RT, cannulas should be secured, RT should be placed, and Foley's catheterization should be done, because after thrombolysis for the next 24 hours we should avoid pricking the patient on any invasive procedure, and we plan to give IV alteplase.
Dose?
Alteplase is 0.9 mg per kg. For her, the dose will give, she is around 50 kg, so her dose will be 45 mg. So we have to give first 10%, that means 4.5 mg we should give within first 1 to 2 minutes. Bolus dilution, with that itself they will be having the dilute will be there. Then we should give our 1 minute, then after that rest of the 40.5 should be given over 1 hour, sir. Within that time we should monitor the BP every 15 minutes, or if we have continuous BP monitoring, or if we have placed already an arterial, then we should monitor that.
What is the availability of 1 vial of alteplase?
50 and 20.
50 mg is commonly available, so you have to calculate the dose properly. Many times what will happen, you have a 70 kg individual, you give 50 mg, which is not sufficient for this patient. So maybe you have to take that additional. That's why the company has come with a 50 vial, 50 mg and a 20 mg vial. So you can take 20 mg and you can calculate, and you have to correct, give the, what will be the maximum dose that you can give?
90.
90. So, fine.
So if we are having this 50 and 20, we can avoid wastage also, because it is very costly medicine.
What happened to patient during this thrombolysis? After thrombolysis?
During thrombolysis, her blood pressure was controlled, sir, and she was actually telling her that her weakness has improved. So we were monitoring her, and she was admitted to our ICU. Then we have to monitor other parameters regarding her nutrition, temperature and also. So temperature should be kept between
Normal
37 and 39. Hypothermia should be prevented with blankets, and hyperthermia also will worsen the prognosis, so we should avoid fever also. Then sugars also should be controlled. Sugar less than 50 is a contraindication. Anyway, her sugar was 140, so it was okay. Sugar should be kept between 140 and 180. Hyperglycemia can also worsen the prognosis. For the next 24 hours we should avoid invasive procedures and all. Then after 24 hours only we should plan for to start around aspirin and all. Then feeding and all, if she doesn't have any problem like aspirin, swallowing difficulty and all, we can start her on feeding, enteral feeding, but ideally after 7 days. Or if at all the patient is very stable enough and power improves, then only we should start on early feeding, sir.
Other measures?
Mobilization very important. Early in the ICU we should give her TET stockings and all. Anyway, we cannot give any heparin or
to prevent DVT. Touch stocking or some other thing?
Any other devices?
pneumatic compression.
Okay. Other than that?
Active limb movements.
Active limb movement is the best thing. Then ask the patient to walk. Then only the parent. Anyway, you will give all patients in ICU. But if the patient is long-standing bedridden, we will have to definitely start.
Early physiotherapy and rehabilitation.
Is very, very important.
What are the expected complications?
Expected complications is first is anaphylaxis to this drug, then bleeding, then
So will you tackle that hemorrhagic transformation?
Yes, sir. So if at all the patient is having a sudden vomiting, worsening of focal neurological deficit, headache and all, we should plan for a emergency CT that time itself.
Before having headache, vomiting, you should pick it up. That is why she is in the ICU.
Drop in GCS.
So any single drop, one drop in M or V, you should immediately identify that. Headache and all, it will take time. So you should identify pupillary asymmetry, all those things you should identify, and you should pick up that faster, and you should take a CT. Definitely CT. After CT?
If the CT is showing bleed, we should stop the thrombolysis that time itself. Then we should, the treatment is...
When the hemorrhagic transmission usually happens? During lysis or after it? Usually it will be after
lysis.
So you need not stop. You will not be able to stop because already the drug would have gone inside. Because last 60 minutes you have already given the drug. Then only slowly the worsening will come. But in between, if you are seeing a worsening, you can stop. But usually it will be after that. Usually once you complete the thrombolysis, only the hemorrhagic transformation occurs. So after the hemorrhagic transformation, what are your treatment options?
So we should keep this patient in a 10% head and elevated position. We should give hypertonic saline and injection tranexamine.
All patients.
It depends upon the involvement.
Depending on the midline shift and mass.
There is a right. Suppose there is a small bleed, it does not require anything.
Life-threatening hemorrhagic transformation is very, very less.
Yes,
It is like less than 2%. If you see less than 10%, you have hemorrhagic transformation. There will be minimal hemorrhagic transformation only. There will be some surrounding area. There will be minimum hemorrhagic transformation. Life-threatening, those who needs decompression is very rare. So that may be either you have selected patient wrongly, maybe you have taken a patient with a low aspects or a high NHS score, those who is not fitting for a thrombolysis. Usually when you fit into the criteria, the life-threatening hemorrhagic transformation will be very less amount of patients only. Those group, how will you manage? That is a question. Those group.
Tranexamic acid can be given, sir. Then ideally to reverse this effect, we should give cryoprecipitate, sir.
Better agent. Recombinant. Factor 7A. These are the available things. So recombinant factors can be given. That is the only one definitive indication for this recombinant factor 7A. That is the one indication. Those who you have given a drug and you have caused a bleed. So that is one indication, and then you have to think regarding your decompression.
Who will have more symptoms, a young patient or old patient, when there is a bleed in the brain?
Young patient.
Why?
Old patient, the atrophied brain, there will be more space for the bleed.
Yes, they take more time to have clinical features. Bleed can be more in old patient, but they have less clinical features.
Any role for CT perfusion images?
CT perfusion images is prognosis, for the prognosis we can take, sir. So if the involvement is like less than 30% and all, it will be giving a good prognosis. More than 30% means the outcome is poor, sir.
So those group of patients are like when you are planning for an, like they have come after the window period. Maybe you are thinking in terms of an endovascular therapy. So you are thinking a large vessel occlusion, whether the patient is going to benefit. Already the perfusion of the brain is affected. There is no point in continuing. Like it is more than 30% involvement or 70 to 100 ml of the brain parenchyma is already involved. There is no point in any of your therapy. So if it is less than that, they will definitely benefit. So you have to select those group of patients. You have come with out of window period, but maybe you can think of an endovascular therapy. You are thinking of an LVO, large vessel occlusion, then you can go ahead with this. Okay.
On discharge, what are medications you advise?
At the time of discharge, we should advise on aspirin and atorvastatin, sir. Aspirin,
BP side.
BP control should be there, sir.
Drug of
What
choice.
medicine you should be used for this patient? His BP on admission was 170.
160, 100, sir.
First BP.
160, 100.
160. So what is the medicine will be suitable for this patient?
Which category?
He is not on any
Calcium,
medication. He is now admitted with a stroke, but BP was high.
Calcium channel blockers.
Why calcium? What is the treatment plan for an hypertensive patient if there is no comorbidities? Suppose there is no comorbidities. What is the treatment plan for a patient who is having high BP?
AC or AC, just ARBs.
Calcium channel blockers or
Diuretics.
So here calcium channel blockers will be better because he has got high systolic BP, elderly individual. So that will be a better choice.
Yes.
So what medicine you can start?
Either cilnidipine or Nicardia.
You don't prefer amlodipine?
Yes, sir.
Why cilnidipine? Is there any added advantage?
No, sir.
There is no advantage of over amlodipine. But pedal edema can be there in amlodipine, that may not be there in cilnidipine like tablets. So calcium channel blockers will be ideal. Any indications for other hypertensive, antihypertensives here? Any other indications? So you have to see kidney, heart, other organs. If they are involved, you have to think other tablets are required.
Beta blockers, sir.
What is echo?
This patient echo was normal, sir. There was no features of any LVH.
Any carotid clot?
We have did an angiogram also, so there was no stenosis.
Any renal failure?
No, sir.
Nothing. So amlodipine or cilnidipine will be okay. Okay. Thank you.
Okay.